although everybody know you. So I think I do not need to say too much about Mark. So Mark is well known to almost everybody here. Other than the president of cardiovascular pathology, he has other life. He is professor of pathology and professor of oncology. So his practice, including both a cardiovascular autopsy and another one is the transplantation. That's learned from yeah, all this pioneer before. I count his paper. He published 250 some papers. I don't know. And then these are original papers. Other than that, have the reviews, have comments, everything. So he's world-renowned expert in microRNA, especially in cardiovascular field. And he is a great leader, we all know that, and make our Cardiovascular Pathology Society a very successful over the past 2 years.
All right, Peter, thank you. That was more than kind, far more than kind. I'm going to go ahead and share the screen and welcome all of you to our SCVP Journal Club. Today, there are a number of papers I'm going to talk about. Some I'm going to go into more in depth, and some of them I'm going to go into less depth. Feel free to either unmute yourselves to comment or put something in the chat if you'd like to discuss something as we go forward. So the first manuscript that we're going to go into more depth on is this recent paper called Unsupervised Messenger RNA-Seq Classification of Heart Transplant Endomyocardial Biopsies by Romero et al. This just appeared in Clinical Transplantation, and a couple of our colleagues, Greg Fishbein and Sylvia Lutovsky, are on this manuscript. And this is similar to what Dylan Miller had covered about a year ago with the molecular microscope, the idea that can you take a transplant biopsy and do RNA sequencing and get a signal that's going to tell you more than what we can do by light microscopy. And so the way they did this experiment was they took 67 biopsies from 47 different recipients and then performed messenger RNA sequencing on those samples. They also did standard histology assessment and simultaneous peripheral blood to measure cytokines and brain natriuretic peptide, or BNP. Additional histology assessment for agreement, I assume that's when they got Greg and Silvio together to agree or discuss what they saw, and then they put all this together: the ISHLT classification, the an unsupervised molecular classification, which was using the optimal.
Hey, Mark.
Yes.
I hate to interrupt you. This is Henry, but we're still on your first SCVP Journal Club slide. If you're scrolling, yeah, if you're moving through them, we're not seeing that.
No, then I did something wrong. Thank you for sharing that. Let's try now. Do you see this? Does it say methods?
Yeah.
Okay, thank you so much. Whoops. Okay, we missed very little. This was the first slide. This is the second slide. So you can see 67 biopsies evaluated by different means. And then they used an unsupervised molecular classification using this method called optimal transport method, and compared gene expression to ISHLT classification and other heart failure methods. This is their table 1A, and it's kind of your standard stuff. There we go. Grab your standard stuff. They're mostly men. They're mostly Caucasian. There are 64 samples. I think of importance is they had 30 samples they called 0R, 23 1R, and 11 2R. About 17% were high-grade rejection, and they came from UCLA and UAB. This now is table 1B. This is the characteristics of the biopsies, whether they were originally called a 0R, a 1R, or a 2R. I kind of highlight a few things of note. The first is that the left ventricular ejection fraction seemed to be the same between the three groups of 55. And often when you have a 2R rejection, we see a decrease in ejection fraction. So that was either odd or they didn't have a lot of samples because everybody was 55 to 55. And that may be true here when we look at BNP. BNP levels are low and appropriate for 0R and 1R, which makes sense because that's really not sort of clinical rejection. But when we get to 2R rejection, we see a big elevation in BNP. And I can come back to this value later, but there seems to be just maybe one value, this 1410. So maybe only one person's had a BNP drawn who was a 2R. And then everything else is about the same, a little lower tacrolimus dose than here. And we know that when you are low on your medications, it's a chance that you'll have higher levels of rejection, as you're seeing here. Okay, so now this is the big problem that people keep finding in what we do as pathologists, which is that we are not great when it comes to publications of being in agreement on different levels of rejection on the hearts. And I highlight these three areas where you had either a blinded pathologist or a center pathologist or the blinded pathologist to the blinded pathologist disagree on a diagnosis severely, calling something a 0R in one case, no inflammation, or a 2R in another case, which is clinically actionable rejection. And I don't know why that is the case. I don't know if anyone on this call was involved. There was a previous paper about 15 years ago where they did something similar and showed poor agreement between pathologists. And there was a question about how many slides were reviewed, whether the most lesional slide was shared between the various institutions. And I don't know here if every slide was reviewed and maybe, again, a lesional area was missed, or maybe someone was calling a Quilty effect as rejection or not. But that just seems like to be a big miss to go from a 0R to a 2R here. It can happen, but it was concerning. And that's one of the points that people who are doing molecular microscope or this paper were trying to say, is that we as pathologists are not great at coming up with the same diagnosis each time. So they took that messenger RNA data, they did this unsupervised clustering, and they had three different unsupervised clustering groups, UC1, UC2, and UC3. And they said that the UC1 samples resemble the molecular signatures of 0R, no rejection, highly enriched for expressed genes related to mitochondrial activity, and low activity of enriched genes related to immune function. So mitochondria high, immune function low. UC2, they showed characteristics of 2R rejection. So that's real cellular rejection, strongly enriching for genes related to immune function, and decreased activity of enriched genes related to mitochondrial function. So that's the opposite. And then UC3, they claim, is sort of in the middle. It has characteristics of 1 and 2, less defined by their mitochondrial or immune response activity, with decreased gene module activities observed in UC1 and UC2. And that probably isn't that surprising. If you think about the fact that 0R has no immune cells in it, this is a picture of 0R from our website. Of course, they're not going to have genes related to immune function. And if you have a 2R pattern, you're going to have lots of cells that are immune cells. They're going to have lots of cells that are going to have immune function. So really, this gene data is basically replicating what we saw by histology. This is now probability of molecular class assignment for each sample, cross-comparing, again, 0R, 1R, and 2R across those different groups. And you can see that about half of the cases for 0R fell into the UC1 group, and 8 of the cases, 72%, were 2R that were in group 2. And then this is sort of a middle group right here, hodgepodge of the different things. If you look at area under the curve for the different groups, you see that, sort of moderate amount of area under the curve. Ideally, this line should go up very high and go across like that. That gets you into the 80, 90% area under curve of 0.9 or above. So this is sort of moderate correlations, as you see right here. This is the cytokine profile, which confirms the cellular composition of the tissue. Again, if you have a lot of immune cells, those immune cells are going to be making interleukins. They're going to be making TNF, all those things, and you're going to have higher levels of them. So higher color, higher levels, highest levels you see in UC3, UC2, and even in 1, 2R, where we know by the histology you're going to have lots of immune cells, whereas for UC1 and 0R, where you don't have immune cells, those values are going to be lower. I don't know why they collapsed 1 and 2R together here. There should have been enough samples of each to show them separately. And then the last thing is BNP is known to be associated with heart failure in the setting of transplant rejection. And so they looked at BNP levels as maybe another way of evaluating how well their UC data worked. And you can see that there's a slightly significant difference between UC1 and UC2 relative to BNP levels. That value is 0.02 and not significant to UC3, which is this intermediate group. But again, we've seen repeatedly that the UC3 is intermediate between the UC1 and UC2, or 0R and 2R. So they show this a little bit here. And then this is really what kind of bothered me as well. Again, they collapsed 1R and 2R together and showed that there was nothing significantly different between BNP between the two groups. But I have a couple of issues with that. First, here they have 2 values for BNP around 1400, and here they have 4 values for BNP. And if you go back to the original table, they seem to have only 1 sample that had a score of 1410, not 4 samples, and no samples that were 1R that had very high levels of BNP. So there's something that is inconsistent between the table, this figure with 2 dots, and this figure with 4 dots. Additionally, from this data here, if they had showed it as a 0R alone, the 1R alone, and the 2R alone, even if they didn't have a large sample number for 2R, and I don't know how many of these came from the 2R or the 1R, it would probably show, as we expect, that the BNP would be higher in the 2R group. And as we know, it makes more sense to lump 0 and 1R together because we don't treat those, and then give the 2R as a separate group. And they had 11 samples that were 2R. So that seems like a really weird way of putting this together. Now, the authors said that an unsupervised messenger RNA-Seq classification for EMBs was developed, which is true, with stronger representation of different biological processes compared to the ISHLT histologic classification. I don't really believe that that second part was proven here. This is what I interpreted, that the unsupervised clustering of gene expression from tissue recapitulates the cells present in the tissue with low to no immune cells present. That correlates with the 0R. And that unsupervised clustering is not really at this point an improvement over histologic interpretation, although correlation between pathologists can still be improved. And finally, the conclusion of the manuscript do not accurately reflect the data or establish a ground truth. So I don't think we've really made progress here with messenger RNA, rather than us still looking by glass slide at these cases. So if anyone has any comments, now's a good time to jump in and give some thoughts on this manuscript.
But I just want to ask you, Mark, are you doing any similar work with larger numbers on these, cytokines, BNP, etc.? Or is anybody doing large series?
Yeah, so I am not, and I don't know who is. If there's a question of whether a specific cytokine or chemokine is truly associated with rejection, one would have to normalize the immune response that you're seeing relative to the immune cells present. And you would probably want to not compare it to 0R, where you're not going to see any immune response, but between potentially a 1R and a 2R, and say, if we normalize everything so that we having the same number of lymphocytes, are we seeing a signal in the more aggressive lymphocytes that we're not seeing in, say, in the 2R situation, then we're not seeing in the 1R, and then associate that either with outcome or need for treatment or BNP or some other measure that they're not seeing. That's how I would approach it, because these are very different biopsies between a 0R and a 2R as far as the cellular composition.
Mm-hmm.
Any other thoughts, comments on this paper? All right, I will keep going. So the next paper is by Mary Shepard's group. I'm glad she's on the call. This is one that we're going to go through a little more rapidly. What's fantastic is Dr. Shepard has been collecting thousands of individuals who've died of sudden cardiac death and have built this amazing repository from which she can ask all sorts of questions, take sort of any phenotype that these people might have, any finding, and say, because I have thousands of people to look at, what is some useful data? And this is sort of a quick hit paper that showed up in our journal, Cardiovascular Pathology, on the role of bicuspid aortic valve in sudden cardiac death findings at cardiac autopsy by Nikhil Chatrath et al. And so the main concept of the manuscript was, at this time, they had over 6,300 hearts of individuals who died of sudden cardiac death. And when they went through it, they found 91 of these had bicuspid aortic valve disease. And they simply asked, in how many of them did the BAV lead to patient death? And how many of them was the BAV incidental? And it turned out that in 53 or 57% of subjects, BAV specifically led to patient death, with aortic stenosis being the most common cause, but also we saw endocarditis, aortic dissection, and aortic regurgitation. And in 38 or 43% of the subjects, the BAV was incidental. So there was no cause of the BAV to this group. This is table 2 from the paper, which shows some basic cardiac measurements recorded in the overall cohort. And the data is fine. I think it would have been perhaps better if they had just split this up rather than saying overall, to had split them into the BAV associated with cause of death and BAV that was not associated with cause of death, just to see if there are any other differences that might have fallen out between the two, particularly ascending aortic circumference may have been one of some interest. So that's it, kind of a quick hit on that manuscript. I again open things up if anyone has anything to add. Dr. Shepard, if you want to say anything about the paper, I thought it was just a nice, quick reminder that BAV can be associated with sudden cardiac death.
Yeah, thanks, Mark, for that. And you're right about separating, as you say, the aortic circumference. I don't think he found differences that I'm aware of, but you're right. We should have said that the fatal cohort, as you call it, and the non-fatal, as we consider, and compared them would have been useful. I agree on that point. I think the big message is, what do we consider incidental? And I think it's something we need to have guidelines on, Mark. Is when do we consider a valve a cause of death? Because bicuspid is so common. Again, mitral regurgitation and aortic regurgitation are difficult concepts at autopsy that we don't really agree on or have guidelines. So I think this is an indicator of, I'm sure, with other people contributing more papers, to talk about what do we mean by a stenotic valve, a regurgitant valve. That endocarditis is pretty straightforward generally.
Right.
Mary, I'm glad you brought that up, because that was one of my questions about the article, is how did you determine whether or not a bicuspid aortic valve was regurgitant without hemodynamic data?
Correct. Well, what we did is we took the dilated aorta. The aortic diameter was above 60 millimeters. So the aorta had to be dilated, number one. Number two, the valve leaflets had to have a regurgitant ridge on them. And number three, a dilated ventricle with a thin wall, remodeling with fibrosis. We didn't highlight this and this because he's a clinician, but I agree we need to do more detail on this. But that's how we define regurgitation, Joe.
Understood. Thank you.
So there's another question, kind of related. They are primary BAV and they are secondary. Is that concept still viable?
Sorry, Peter, which was that question about primary and secondary, is it?
Yeah, they are primary and secondary, right?
Oh, I see. If you'd secondary, like say aortic or mitral regurg due to failure, well, then you'd have cardiac failure. And we really don't have that in the sudden death. By definition, a failure, they're not sudden death.
Is that what you were talking about, Peter? Or were you talking about acquired fusion events of the aortic valve, like a rheumatic or a post-inflammatory valve, where you get basically fusion of two of the cusps, so-called acquired bicuspid? This terminology I really dislike, but
do we separate
is that what you're referring?
Exactly.
Yeah, exactly. Yeah, so
we didn't have commissural fusion. None of them had it was the raphe in the center of the leaflet, right and left, or with non-coronary. So we didn't have anything with commissural fusion. In these, we were quite, as we say, conservative. And to be truthful with you, I don't see rheumatic valve disease. Okay, with aortic stenosis, but generally they were elderly, the aortic stenotics. But we didn't, it's rheumatic. We find almost no cases causing sudden death in our population.
Great. Very nice discussion. So we're going to move on to another paper by the Shepherd group by Giuseppe Ciliberti, coronary artery dissection and myocardial infarction with non-obstructed coronary arteries, insight from a UK nationwide autopsy-based registry, another brief report. And a couple of things. So here, again, they went back to this biobank they had of over 5,300 cases. The last time I think it was over 63. I'm not sure why there's difference. It may have been the years, or they just continue to acquire more and more hearts. And they compared SCAD, spontaneous coronary artery dissection, of which they found 18 cases, and MINOCA, myocardial infarction with non-obstructed coronary arteries, which they had found 37 of these cases in the biobank. And just to let everyone know, the MINOCA, there is a definition of this, which is it incorporates the universal definition of an acute myocardial infarction. So by definition, everyone with MINOCA has MI. The presence of non-obstructive coronary artery disease on angiography, defined as no coronary artery stenosis greater than 50% in any potential infarct-related artery, and the absence of another specific clinically overt cause for the acute presentation. So it's an MI with no good coronary reason or any other reason for it to have occurred. And this was a nice picture of histology of spontaneous coronary artery dissection. It's a beautiful example where you can see complete occlusion of the lumen, the true lumen here, with the false lumen here with lots of blood, and again, compressing, and that can lead to myocardial infarction, arrhythmia, certainly sudden cardiac death, as seen here. And this is the key data table from this manuscript, where again, they compared the 18 cases and the 37 cases between them. I've highlighted some of the key differences. That sudden coronary dissection is much higher in women. That's been reported, and they're replicating that here, whereas only 40% of the cases of MINOCA were in women. That 100% of the people who presented with sudden coronary artery dissections had cardiac symptoms, whereas only half of the patients with the myocardial infarction group had that. That substance abuse is known to be associated with MINOCA as well, particularly sort of cocaine or anything that can cause a vasospasm of the coronary vessel. And you're seeing that here, about 40% of the cases, with none of the cases in spontaneous dissection. Peripartum is also well known to be associated with SCAD. And again, 28% of the cases, or about a third of the women involved in this who had this disease, were in the peripartum state, very low levels in MINOCA. And then finally, by definition, MINOCA has myocardial infarction, but only 28% of people with spontaneous coronary artery disease had an infarct. Remember, these are all people who died of sudden cardiac death, so I would imagine that the remainder of them would probably have an arrhythmia or some other cause of their sudden death. So conclusions from the manuscript is that SCAD and MINOCA are distinct entities with different clinical and pathologic profiles. I think that was nicely demonstrated by these key differences between them, although both can have ischemia as part of the mechanism. And they really talked about fibromuscular dysplasia. They didn't see it in any of these cases, although they did see it in two brothers who were unrelated to these cases, but left out, or left in, I should say, as a pertinent possibility, is that fibromuscular dysplasia may exist in non-cardiac locations, which they didn't have access to those tissues. So that, again, is sort of a nice paper reminding you about these two entities. Could be causes of sudden death, but they really are distinct. I'm again happy to open this up for other comments. People want to say anything, or Dr. Shepherd, if you want to add anything I may have missed about the manuscript.
Just to say the variable in numbers, Mark, is because these were done at different times by fellows. So as our numbers accumulate with each study, but this was an earlier study with smaller numbers.
Yeah,
so each year we are adding about 500 cases.
Yeah, that's exactly what I was thinking, but I wasn't sure. So thank you for clarifying that.
So in the MINOCA group, in the MINOCA group, I understand that the lumen, they don't see any arterial lesions or doesn't change anything. So do we see any change in the tunica media or adventitia?
No.
The size or thickness of the tunica media?
In the MINOCA group, the coronary arteries are histologically, both macro and microscopically normal. We see nothing really.
Gotcha.
Okay, let's move on to the next manuscript, another paper that came out in Cardiovascular Pathology recently. Postmortem diagnosis of Takotsubo syndrome on autopic findings. Is it reliable? A systematic review. That's an important question that this group tried to address. And so I think most people on this call are familiar with Takotsubo syndrome, also known as stress cardiomyopathy. It's a transient left ventricular systolic dysfunction without obstructive coronary artery disease. It's seen in individuals with intense physical and emotional stress. So it's been described that during World Cup soccer play, a lot of men show up in the hospital after their team loses, sometimes wins, from this stress cardiomyopathy. It's also increased in postmenopausal women. It's associated with elevated troponins and STEMIs. So this really can cause cardiovascular injury. There is a leading hypothesis is that it's catecholamine release that's associated again with this physical or emotional stress. You get high catecholamines, and that leads to Takotsubo syndrome. And grossly, there is LV apical ballooning, which is the key finding by imaging by echo, which is used to make the diagnosis. So that's made clinically. And then the question is there anything at autopsy that we can point to once we know someone has had this disease and dies, that should someone be found dead on the street, for example, without a clinical history, you say, oh, well, this is Takotsubo syndrome. So the group that did this study, they did a systematic literature search, a PRISMA-based method going from 2004 to 2023 for all the papers they could find on Takotsubo and gross heart cases. And they found a bunch of manuscripts, as you see here, but after they screened them and excluded them and went down, they ended up with just 11 studies. And these 11 studies, a lot of these are just case reports with only a few case series mixed in between. So not that much data, unfortunately, on which to build these conclusions. And so this is kind of putting all of the results together from the different findings. That they said that the macroscopic structural changes were absent or non-specific. So despite the echo findings that they have that may be more transient relative to when these individuals died, they didn't see the macroscopic change. And Takotsubo, and I'll show a picture in a moment, is, I think it comes from octopus pods, or this ballooned apex of the heart. They did find contraction bands in 9 of 11 of the cases or case reports that they saw, that there were inflammatory infiltrates, not necessarily neutrophils, but other immune infiltrating cells. They saw wavy myocardial fibers in some of these cases. They saw hemorrhage in a couple of cases, fibrosis, non-specific interstitial fibrosis, and even they saw wall rupture in a case as well. But at the end of this, when they put all the data together, they said there's no conclusive microscopic evidence of Takotsubo syndrome that they saw. So which is to say that if someone presents with sudden cardiac death to a medical examiner, it would be really hard to point to them and say, oh, I can tell from this heart that this patient had Takotsubo. And that's really a clinical diagnosis needs to be made that way. So any thoughts or questions on this one?
Well, Mark, I'm just wondering with this, as you say, it's non-specific, but the other thing is these changes exactly what you see with resuscitation, if they've been resuscitated. So you're dead right, distinguishing in them is impossible.
Yeah. Do you have any in your case series?
No, I've had no. It could have been a Takotsubo with the MINOCA cases. They could have been due to that, but not that I'm aware of that any of ours were associated with a stressful event prior to death. But then we're often not told of this, you know, that an argument with their spouse, that might be kept quiet. A domestic, we call it. But I think it sums it up that we can't really tell. Has anybody any other experience with being asked about them or a case at autopsy?
Yeah, I think this is an entity where by the echo, when the echo is perfect, you can make the diagnosis.
Yeah.
But if you don't have that echo that's perfect for it, you really can't, is kind of what they're saying. And maybe we need, it's not clear where we go from there, but what they're suggesting is that based on all the publications that are out there, there's no really specific way of making this diagnosis, which is unfortunate for medical examiners.
Mm-hmm.
Yeah. Oh, sorry. Peter, were you going to say something?
Yeah, go ahead.
Oh, no, I was just going to chime in and agree with both Mark and Mary. We see this a lot, very similar to resuscitation related injury. And, if the patient wasn't resuscitated, then, and you had some sort of a history that might be compelling for it, I think you could make a suggestion or take a stab at it. But at the same time, it is nonspecific. And certainly if the patient has been resuscitated, I don't think there's any way to be able to really call this. And just to throw in my hat with what you all are saying and agree with you on that particular point. I don't think I could do it without an echo or very particular clinical circumstances.
Mm-hmm. Peter, go ahead.
Yeah, from the name, it sounds like Asian population is more common to have this syndrome.
Well, it got diagnosed initially in Japan, and then it's kind of been found around the world, I think. I
understand. But from your 11 case, they are more Asian related or something?
Again, that's, I think, where it was found and diagnosed, but I think it's worldwide now. I know that there's always reports of this going up during World Cup games and Super Bowl in the United States, and where people are very emotionally invested in things that it can stress people out significantly. Show up with chest pain in the hospital, and their heart looks like this. Yeah. All right. Great. So one last manuscript. This one showed up in European Heart Journal. This is a little more of a research-minded manuscript, but I thought it was going to play nicely with the paper I just presented, because the paper just before says we don't have a specific finding, and the title of this one was so intriguing to me, which is Takotsubo syndrome is a coronary microvascular disease, experimental evidence. So maybe we've been going in the wrong direction as far as what we're trying to find for this disease. So in this manuscript, which is really more of a basic science approach, the hypothesis was that coronary microvascular dysfunction is the precipitating cause for Takotsubo syndrome, and that an imbalance between myocardial blood flow, MBF, and myocardial work oxygen demands produces the syndrome. Okay, so they're saying that microvascular dysfunction is the problem, that they admit that catecholamine release is important, but it's this microvascular challenge which is causing this to happen. And so to look into this, they used a knockout mouse model, this KCNA5 or KV1.5 null mice, which are known to have myocardial blood flow changes, coronary metabolic demand mismatch. And on top of that, they used a transaortic constriction model where they take that mouse and they put a band around the aorta. It kind of closes off the aorta and causes heart failure. So there's too much pressure behind it. And a TAC model has been used in all sorts of different cardiovascular disease states. So it's not at all specific for Takotsubo. And in fact, they tried a couple of other approaches as well, but nothing else seemed to work as consistently for them as this TAC model. They used echo to assess systolic left ventricular function. They looked at blood flow, also assessed by contrast echo. They used a medication called Chrominar, which I'll come back to in a bit, which can be used to induce coronary specific vasodilation. And then they did some RNA sequencing at the end, because everybody likes to do RNA sequencing. So here are some of the results. This is just showing that this model actually works. This is the echo showing these knockout mice had ballooning of the apex, which also they noted bulges during base contractions. So this is the control animal, and it's sort of a normal left ventricle. The apex is down here. This is now after 2 weeks of the band, the TAC, putting the band around the aorta on the knockout animal. You see this ballooning here at the apex, and that's like this octopus pot that it's named for, as you see here. And then they showed is if you remove the band, so 2 weeks after you remove the band, it goes back to the normal physiology. So this isn't a permanent change. This is a temporary change. And over here, they looked at fractional shortening in wild type and the knockout mice. And you can see these kind of move along the same way between base and apex. And here we see the big finding, which is in the apex of 2 weeks of TAC band, that you have a marked decrease in fractional shortening relative to the apex. So that's really showing that this model is consistent with what people see in Takotsubo. They also used norepinephrine as that stressor to induce like catecholamine release. And they noted that blood flow increases norepinephrine, kind of, again, setting up the model. This is at baseline with the TAC, putting that band on. This is the amount of blood flow in the heart at the base and the apex. And when you give norepinephrine to serve as that stressor, blood flow goes up in the wild type, also in the KV knockout animal, with the apex being significantly lower. Now, what's kind of what their discovery was, the reason I think this was in European Heart Journals, this is an old drug, Crominar, which I'd never heard of before, but apparently it was used some time ago to cause vasodilation of the coronary. It's very specific for the heart, unlike other areas. And what they showed is that if they added this Crominar, it resolved this TTS phenotype. So here you see that ballooning again, 2 weeks with TAC, but if you add the Crominar, you don't have that big balloon in the apex anymore. It looks like a more normal physiology. You can see that here, by fractional shortening, that with 2 weeks of the band, you lose the fractional shortening. But if you do the same exact experiment, but you add this drug, this Crominar, you're not getting that same change in fractional shortening. And then 4 weeks later, you're still doing really well. And again, here in that same knockout mouse model, you have improved blood flow with the Crominar on board, as opposed to when you don't have it on board. So I think that's a really interesting finding that they made that's going to potentially lead to some clinical trial work. See, this might be a drug that's useful in that setting. The last part of it was the RNA sequencing data. They showed this figure, which is very difficult to see what they're doing because they use the same color scheme, red, blue for genotype and location. So I guess this is genotype up above and the location is below. It'd be nice if they change some color, make it easier on me. Anyways, they're showing different gene expression patterns, and they put all the genes together. They can show differences in fatty acid metabolism, oxidative phosphorylation, and hypoxia as being a differential between the different groups here as well, and the TTS groups. I don't think that's that important for their key findings. But the key findings, though, is that in Takotsubo syndrome, it may be the result of reduced blood flow to the apex, which I think is somewhat novel, and that this drug, Crominar, is an unused but approved drug that increases coronary blood flow, resolves TTS in this animal model. And it really got me thinking about whether or not, knowing this about blood flow, there be any histology or immunohistochemistry specific for reduced blood flow that will help make the TTS diagnosis. So that's a question where, if you had these cases, we could start to think about looking at the microvasculature, maybe apex and base, and see if there's any differences to be found. Any thoughts or questions about that?
Mark, I think the microvascular is so difficult, isn't it, for us? We pathologists are terrible. Well, we're worthless, aren't we? You know, I look down the microscope at the small vessels of the heart, and I see such variability that really saying what's abnormal. The papillary muscles, for instance, there's medial hypertrophy of the vessels. So I think it's just impossible. I don't know if anybody's in the human or, you know, looked at the thickness of the wall and the luminal diameter, and, you know, it's a very difficult, isn't it, for us? The functionality and imaging is taking over, and pathology isn't really following. We have no markers, as you say, unless you know of one or anybody else.
No, so I agree with you. I think by histology, the fact that no one's seen this before, I don't think anyone's going to start discovering it now and say, aha. But if someone has an idea about an immunohistochemistry marker, and I don't know anything about this, is not my area, whether or not there are proteins that get turned on in vasculature related to changes in blood flow that you could follow. If you took an apex and a base and you saw a difference in expression of a particular IHC marker that may indicate this, might be useful in the right clinical setting. I don't know that that's true. A lot of speculation there. But I think the point is we can use some of these more basic science researcher papers to have us think about ways that we can do a better job making diagnoses. So whether or not there's any value of this discovery relative to what we can do at Takotsubo, conceptually it's useful to occasionally look at some of these more basic papers and say, how does this help us get to a diagnosis? All right, well, let me just sum up. We talked about these 5 manuscripts. I kind of have bullet points of take-home messages for each of them, and then I think we can head off for the day. The first paper was about gene expression in transplant on endomyocardial biopsies, and I really think it was an interesting paper, but in need of further development to supplant us as pathologists. Bicuspid valves are the cause of sudden cardiac death about 60% of the time. I think it's 57%. It's useful to think about that. SCAD and MINOCA are both rare causes of sudden cardiac death, but they are important and they are distinct entities. There are no specific histologic findings of Takotsubo syndrome as seen at autopsy, and reduced coronary blood flow to the apex may be the cause of Takotsubo syndrome. Whether or not that's going to help us one day, I don't know. So that's all I've got. Again, happy to take any additional thoughts or comments that people have.
Yeah, that's amazing, Mark. In about 40 minutes, you cover all 4 papers. Gosh, that's amazing. Well, look at this one. I say, you know, I'm sitting here. I think looking at the paper, I say, if one case, you know, one kind of disease sends some sample to cardiovascular pathologist, we should have much more samples, right?
Yeah.
I think it's a good thing for us to get thinking, Mark, on where we can all collaborate and ideas for, I say, what we know, what we don't know, what we need to do more work on in transplant and non-transplant. It's a very good platform. Thank you.
Yeah, you're welcome.
I really like the idea of IHC in a kind of inducible environment where you might have kind of an anoxic injury of some sort to be able to use. I know we use models, you know, in the kidney, for instance, like in clear cell carcinoma, we use some markers that can be inducible in order to really test if that portion is upregulated, and that can happen in any tumors that are really anoxic. So I believe it's CA9, for instance, is an inducible protein that you can end up, and correct me if I'm wrong, if someone else is on here that I'm off base on, but I believe CA9 is inducible, wherein you have it in a hypoxic environment, you end up expressing this in a more robust fashion, and that can be translated on IHC. So certainly something that could be in parallel with the last paper you presented, and then be able to see it, you know, on our routine sections that we take and tested in that environment. I'm sure there are other analogous proteins and other expression profiles that we could look at, but I agree that, you know, it's a great place to collaborate and to really start to stretch our traditional thought processes and where we can go with it. And then to Mary's point with the microvasculature, it's incredible the variability that we see. And we spend so much time talking about the epicardial coronaries, which are important and extremely, you know, a big part of the story, but the microvasculature has got to be huge too. And we just don't have enough information or enough really robust studies to understand what we're seeing and how that translates to disease and symptoms in our patients. So great ways to bring about more ideas and more collaboration. Thanks for all of those articles. Really well done.
Yeah, just follow up Melanie's point. I think it's a very important to have a collaboration to study. And in this new era, we have to keep in our mind their kind of machine learning, their AI, which can do enormous amount of analysis of what we pathologists cannot do by eye ourselves. If we scan the slide, do something really big, maybe something could come up. Not possible with our traditional eyeball.
Yeah, agree. All right, everyone. Well, let's end this now. So take any more of your time. Thank you all so much.
Oh, there's one question. Just one question.
Oh, there's a question.
Mary?
I'm sorry.
Mary, you have a question?
No. Just say waving goodbye.
Marianne, did you have a? Or you just no? Okay.
Just waving.
Just waving.
Okay. All right. Very good. Mark, you want to make any comment out of 1 or 2 papers? to cardiovascular pathology?
Yeah, I'll see what I can put together for you, Peter. That sounds great.
Thank you. This is very good. Thank you so much for the inaugural journal club this year.
Okay, very good.
Many